Okay, let's start. Okay. Which of the following histopathological findings are most likely to be present in this patient adrenal glands? Okay, let's see the options. Okay, now read the question and try to make a diagnosis here. Okay. Okay. So there's a 34-year-old woman who has weight gain over the past year, weakness, easy bruising, and irregular menstrual periods. Okay. Blood pressure is also elevated. Elevated serum cortisol that is not suppressed by the after the administration of low dose dexamethasone. Okay. 24-hour urinary free cortisol is elevated. Plasma ACTH is also elevated. Okay. Which of the following histopathological findings are present in this patient? Okay. Is where is the main pathological site? Is adrenal glands or is it other than adrenal gland?
Other than
Other than
adrenal.
adrenal.
Yes. Okay. So because if the main pathological site is adrenal glands, what will happen to the ACTH levels?
Decrease. Decrease.
It will be done with negative feedback.
Yes, they will be decreased because the normal response of pituitary to increased cortisol levels is decreased ACTH, right?
Decreased.
But in this case, we can clearly see that ACTH is also elevated and cortisol is also elevated. That means that the main pathological site is out of the, it is out from the adrenal glands. It can be pituitary, it can be, it can be an ectopic site as well. Okay. Okay, so it is a secondary cortisol, hypercortisolism. Okay, okay. GFR. Okay, so zona glomerulosa. Zona glomerulosa produces which hormone?
Aldosterone.
Aldosterone. Zona fasciculata produces
Cortisol.
Cortisol.
cortisol. Zona reticularis produces
Androgen.
which hormone?
Androgens.
Okay, out of these three layers, which layer is regulated by ACTH?
Fasciculata and
Fasciculata or reticularis? Which
Radicularis.
one?
Yes. Both.
Both are, remember this, both are regulated by ACTH. Okay. Reticularis is also regulated by ACTH. Remember this. Okay. So this is very important. Okay. Zona fasciculata reticularis. You can remember this by mnemonic GFR, glomerular filtration rate, GFR. The first one is glomerulosa, second one is fasciculata, and third one is reticularis. Okay, and you can clearly see F and R are regulated by ACTH. Both of them are regulated by ACTH. So if ACTH is high, you are going to see increased secretion of both cortisol and dihydroepiandrosterone. Okay, cortisol and dihydroepiandrosterone. Okay, and mineralocorticoids, the glomerular layer is not regulated by ACTH. That's why if the high cortisol levels is not due to a primary cause, then you are not going to see hyperaldosteronism. Okay, you are only going to see hyperaldosteronism if the main pathological site is within the adrenal glands. Okay. Okay. Now come back to the question. Okay. Option number A will not be the right answer because we know glomerulosa produces which hormone? Aldosterone. And in our question, the elevated hormone is cortisol, and that is due to increased ACTH. Atrophy of all layers of adrenal cortex. This would be the right answer in which case?
Addison
Exogenous.
disease.
Yes, it will be the right answer in Addison disease. In Addison disease, you are going to see atrophy of the layers of all layers of adrenal cortex. Okay, in adrenal insufficiency. Okay, hyperplasia of the adrenal medulla. This would be the right answer for what diagnosis? Option number C.
Pheochromocytoma.
Pheochromocytoma.
Very good. It is going to be C and E. Both can be the right answer for pheochromocytoma. Okay. Okay. Let's move on to the next one. Which of the following is the most likely to be found on autopsy? Okay. See the options. Okay. Now, comes back to the question. Okay, let's see what is happening in this question. 50-year-old man brought to the emergency department. Emergency department, okay. Sudden severe headache, okay. Nausea, vomiting, started earlier in the day. Okay, severe headache, nausea and vomiting. Okay. The patient has mild headaches and decreased libido over the past 3 months. Okay. No other medical conditions, takes no medication. So reveals bilateral visual defects, bilateral visual field defects, and impaired extraocular eye movements on the right side. Okay, shortly after being admitted to the hospital, he becomes acutely hypotensive and loses consciousness. The patient dies despite aggressive resuscitation efforts. Which of the following is the most likely present in this patient? Okay. Bilateral visual field defects, deficits, and impaired extraauricular movements. Okay. Bilateral temporal hemianopia occurs due to the pressure at what area of the optic pathway?
Pituitary.
Asthma.
Pituitary
Optic
adenoma.
chiasma. What
Chiasma.
structure is present close to optic chiasma?
Pituitary gland.
Pituitary
Pituitary
adenoma.
gland is present close to a optic chiasma. Okay, that can also explain the sudden severe headache in this patient, and decreased libido can also be explained by pituitary. Okay, so bleeding within the putamen is not the answer. Ruptured intracranial aneurysm. Okay, if D is the right answer, then how are we going to explain the bilateral visual field deficits and the decreased libido in this patient, right?
Can't explain.
Okay. Dissection of the internal carotid artery can also does not explain these impaired extraocular eye movements and the bilateral visual field defects. Okay. Dissection in the cavernous venous sinuses, thrombus in the cavernous venous sinuses can explain the impaired extraocular eye movements,
But not.
but it cannot explain the decreased libido and as well, and the headache and severe headache can be explained by thrombus, but the bilateral visual field deficit cannot be explained by that. Okay, all of these symptoms can only be explained by a pituitary apoplexy. Pituitary apoplexy. And in pituitary apoplexy, usually there is a pre-existing adenoma. And when there is an acute pituitary hemorrhage, we are going to see severe headache, bitemporal hemianopia, and ophthalmoplegia as well. Okay, remember to differentiate pituitary apoplexy with the other types of pituitary adenoma. In the other types, you are not going to see ophthalmoplegia. Okay, and in pituitary apoplexy, you are going to see cranial nerve number 3 involvement. Okay, And you are also going to see hemodynamic instability as well in this patient. Okay. And due to the severe hypotension, why does the patient becomes hypotensive here? Due to central
Because there is no
adrenal,
aldosterone hormone.
due to
All
central,
hormones from the pituitary gland and
yes, because the
abruptly
patient began
declined.
pan hypopituitarism, and then the patient developed adrenal insufficiency as well. Okay. Pituitary apoplexy. Okay, pituitary apoplexy is no longer written here in the. Okay, in Sheehan syndrome, you are not going to see the involvement of cranial nerve number 3. Remember this. In Sheehan syndrome, okay, but in pituitary apoplexy, in which there is hemorrhage within the pituitary gland, you are going to see cranial nerve number 3 involvement. Okay. Latinoma, pituitary adenoma. This is written in the previous first aid. In the previous first aid, it was written in much more detail, but in the new first aid, they has decreased the details. Okay, pituitary apoplexy. What happens in pituitary apoplexy? There is hemorrhage within the pituitary gland, and due to that hemorrhage, you are going to see cranial nerve number 3 involvement as well. Okay, and other than that, you are going to see optic bitemporal hemianopia as well. Okay, see the where is oculomotor number 3 is present. So this is the pituitary gland, and you can see this is the oculomotor nerve. Okay. So when there is hemorrhage within the pituitary gland, it is going to cause an expansion of the area covered by the pituitary, and then it is going to cause compression at the oculomotor nerve and the optic chiasma. Okay. So because in Sheehan syndrome, we are only seeing infarct. We are not seeing that there is hemorrhage there. Okay. So to differentiate between Sheehan syndrome and pituitary apoplexy, remember the involvement of cranial nerve number 3, whether the extraocular movements are impaired or not. Okay. This is one very important effect in acute hemorrhage in the pituitary gland, pituitary apoplexy, cranial nerve number 3 involvement, bitemporal hemianopia, severe headache, panhypothyroidism, severe hypotension. Okay.
Excuse me, sir. I could not understand the cause of hypovolemia, that is low blood pressure in pituitary.
Severe hypotension occurs due to the adrenal failure. Due to the adrenal failure. Okay.
Just now
Central
you
adrenal
told,
failure.
yeah, just now you told that adrenal gland glomerulosa is not controlled by pituitary ACTH, right? Then
Yes, but cortisol is controlled by the adrenal glands, and cortisol helps to maintain the vascular tone by potentiating the vasoconstrictor effects of the catecholamines. In the absence of the ACTH, the cortisol will be less, leading to severe hypotension and distributive shock. Okay.
okay, thank you so much.
Okay, and see, this is a pituitary adenoma in which we are going to see the hemorrhage, and due to the hemorrhage, you can see that oculomotor number 3 is compressed, the optic chiasma is compressed. Okay. Severe hypotension due to central adrenal failure. Okay. The lesions on her eyelids. Do you people know the name of these lesions?
Xanthelasma.
Melasma. Eye melasma.
Plasma.
Yes, these are centralismus. These are these. Okay. They occur due to the
Lipids.
lipid-laden histiocytes in the skin. Okay, especially the eyelid area. Okay, so they occur in the hyperlipidemia conditions. Okay, okay. So if you see a patient of this, so what will be the answering?
Serum lipid ampoule glucose.
B.
Yes. Lipid profile.
Serum lipids,
Yes.
lipid profile, because the cause of this is hyperlipidemias.
Lipidemia.
Okay, yeah, okay. These are xanthelismas which occur in hyperlipidemias. Okay. Which of the following is the most underlying cause of this patient condition? Okay. See the options. Now read the question.
What is the causing of the hyperlipidemia in the British cases? This sign and eyelid as it's becoming
There is a
in
13-year-old boy, abnormal growth. First, we will see all the abnormal findings in this patient. Okay, first is abnormal growth. He has grown rapidly over the past 10 months and is much taller than his older brother and other children of his age. Okay, hard time finding clothes that fit him and that has had to buy new shoes for him each month due to increasing foot size. Excessive sweating. Okay, both parents are of average height and have normally proportionated limbs. Patient is above the 99th percentile for height. Long extremities with large hands and feet and lower jaw is protruding. Which of the following is the most unlikely underlying cause of this patient? Okay. What is the diagnosis?
Gigantism.
Giantism, yeah.
Gigantism, and it occurs due to
Due to
large,
increase
High
growth.
level
large
of
amounts
growth
of
hormone.
growth
Amount of
hormone.
growth hormone. D from the liver. Yeah.
Which is acromegaly. And in acromegaly, we know that we are going to see coarsening of facial features, protruding jawbone. We are going to see excessive sweating. We are going to see a impaired glucose intolerance as well. Okay. Okay. So, okay. So E is not the right answer, right? A is also not the right answer. Increased pituitary gonadotrophin release. No. Okay. So growth hormone stimulates the release of IGF-1. IGF-1 is produced where?
From liver.
In the liver.
In
Liver.
the liver. IGF-1 is produced. Growth hormone causes the secretion of IGF-1 where? From the liver. Okay. Stimulates IGF secretion by the liver. Okay. It is going to increase by the liver. Okay. It was secreted by liver in response to growth hormone. Okay. Okay. So option number F is not the right answer. Okay. So the right answer is going to be option number D.
Yes.
Okay. Excessive liver production of IGF-1 by the liver, not by the hypothalamus. Okay. Okay. Okay, then. Okay. Without treatment, the patient projected height will most likely be shorter than the average due to which of the following effects? Okay. The mother has noticed that her daughter has developed breasts and is much larger than than most of her classmates. Weight is at the 50th percentile, height is at the 95th percentile. Physical examination shows Tanner stage 3 breast development and coarse pubic hair in a 6-year-old patient, in a 6-year-old girl. She is diagnosed with idiopathic precocious puberty. Okay, the cause of idiopathic precocious puberty is increased sex hormones, or is it due to increased growth hormone?
Sex hormones.
Sex
Sex
hormone.
hormone. So D and E are not the right answer, right? In D and E, we are also going to see increased height, but we are not going to see increased coarse pubic hair, Tanner stage 3 breast development in a 6-year-old girl. That things cannot be explained by increased growth hormone. Increased height can be explained by growth hormone, but the other features which are present in this patient cannot be explained by growth hormone, right? Okay, he is asking, uh, without the treatment, the patient projected height will most likely be shorter than the average. What is the cause of that? Why the height will be shorter?
Due to the excessive estrogen that affect on the growth plate. That's why
But
the girls are short-heighted than the boys now, because they get early spur of estrogen, which early closes the
okay,
growth
in
plate.
yes, even in the growth, even when there is acromegaly, you are going to see same. The increased height is occurred due to the unfused epiphysis. The increased height that is occurring, it does not occur in the diaphysis. The epiphyseal plate is involved in the in increasing the height. Okay, and if there is exposure to estrogen at a much more early age, then the epiphyseal plate will fuse at a much more early age, and we are going to see shorter height because of the closure of the epiphyseal plate, the growth plate. Okay, so because the growth plate closes prematurely, and why it closes prematurely? Because it has been exposed to the estrogen at a much early age. Okay, so the right answer is going to be the epiphyseal effect on the long bone epiphyseal plate, estrogen effect. Okay. Okay. So in the question, he is asking which of the following pituitary hormone is most likely to elevated. Okay. The patient is a 29-year-old man, progressive headaches, fatigue, and visual disturbances. Okay. Headache, fatigue, visual disturbances. The patient had a sarcoidosis a year ago. after having a dry cough and hypercalcemia. Okay, patient was of the sarcoidosis. Okay, treated with oral glucocorticoid therapy, which was discontinued after 6 months due to improvement in symptoms. Bitemporal visual field defects. Okay, the patient has shown mild hypercalcemia. Okay, but the remainder of the followings are normal. Serum glucose, creatinine, and electrolytes are within reference ranges. MRI of the brain reveals a soft tissue mass involving the hypothalamus and the pituitary stalk. Okay, so which of the following hormone is going to increase when you are going to? So basically, he is asking that if you cut off the supply line from the hypothalamus to the pituitary, then which of the following hormone is going to increase? Okay, hypoth for the adrenal glands, which hormone is produced by hypothalamus?
ACTH.
Yes.
ACTH is produced by the pituitary.
Pituitary, vasopressin.
A CRH,
Vasopressin.
corticotropin releasing hormone, is produced by the hypothalamus.
Okay.
Corticotropin releasing. What is the function? What is the function of corticotropin hormone on ACTH? Does it stimulate the release of ACTH, or does it
Stimulate.
inhibit the release of?
Stimulate.
Stimulate.
Increase.
Stimulate the release of ACTH. If there is no CRH, there is going to be no ACTH. Okay, and if you cut off the supply, ACTH is going to decrease, right? Okay. Now
Yes.
comes to the TSH. Hypothalamus produce thyrotropin releasing hormone, right? If you cut off the supply of thyrotropin releasing hormone, what will happen to the TSH?
Reduce.
It is going to
Reduce.
reduced. If you cut a vasopressin is produced where?
In the posterior pituitary.
From hypothalamus.
Hypothalamus and
Hypothalamus.
Yes, it is produced in the hypothalamus and reduced and secreted by the posterior pituitary. If you cut off the supply line, vasopressin is also going to decrease. Okay. Okay, can you see this table? Hypothalamus and anterior pituitary. CRH from hypothalamus and ACTH from anterior pituitary. GnRH from hypothalamus, LH and FSH from anterior pituitary. TRH from hypothalamus and TSH from the and TSH from the anterior pituitary.
Anterior pituitary.
Growth hormone releasing hormone from the hypothalamus and growth hormone from the anterior pituitary. Okay, now see what is happening in prolactin. The hormone,
Dopamine is
yes,
This
the
inhibited by
hormone
dopamine.
secreted by the hypothalamus for the regulation of prolactin is dopamine.
dopamine.
Dopamine inhibits the release of prolactin. And if you cut off the supply line, there will be no more dopamine, right? And then you are going to see increased secretion of prolactin.
Prolactin.
Okay. So what will be the right answer here?
Prolactin.
prolactin.
Very
C.
good.
C.
Very good. Prolactin is the only
Doctor,
hormone which is
in
negatively
the
regulated by
previous
the
question,
prolactin is the only hormone which is negatively regulated by the hypothalamus. Okay.
Hypothalamus.
Okay. Which of the following additional finding would be most suggestive of increased insulin resistance in this patient? Okay. See the options. You comes to the Okay. So he is asking which of the following is going to be in which is of the following is going to be an indicator of increased insulin resistance. Okay, our patient is 58-year-old, onset of chest pain. Okay, 26.9 BMI, SPNT showing non-specific ECG changes. Okay, fasting serum glucose is 160. Although he has not been previously diagnosed with diabetes mellitus, serum triglyceride levels are elevated, HDL are low. Okay, insulin resistance is seen in type 1 or type 2?
Type 2.
Type 2
Type 2.
diabetes.
Okay,
Type 2.
so we know, yes, and we know greater is the weight of the patient, greater will be the insulin resistance.
Yeah.
Okay, greater will be the visceral fat, greater will be the insulin resistance, greater will be the BMI of the patient, greater will be the insulin resistance. Okay, so in other words, can I say greater would be the waist circumference, because waist circumference is an indicator of the obesity of the patient, right? Same
Yes.
like his BMI. So can I say greater will be the waist circumference, greater will be the insulin resistance? If I said this statement, will that statement be correct?
Yes, correct.
Yes. Yes.
Yeah.
Yes.
Increased waist circumference. Okay. Is there a- Which of the following changes are circumstantial expected to this in patient? Okay. Okay. First, see all the abnormal findings in this patient. 37-year-old woman. Okay. History. Okay. The patient has a 2-month history of abdominal pain, salt cravings, and weight loss. She also has dizziness on standing. Okay. Orthostatic hypotension. Okay. Abdominal pain, salt craving, weight loss, and orthostatic hypotension. Okay. Okay. Has no chronic medical condition, takes no medication, tobacco, alcohol. Okay. Her mother and sister have hypothyroidism. Her mother and sister have hypothyroidism. Okay. Do you know why the patient, why the examiner has written this statement here? Do you
To
know?
describe
It
Because
is autoimmune
this
disease.
the
Autoimmune
autoimmune
disease.
disease in the family.
immunity.
Okay. Okay.
Autoimmune
Okay,
disease
let's
consequence.
first diagnose this patient, then we will talk why this statement is very important here. Okay, the blood pressure is 100 by 70 on standing on spine and 80 by 50 on standing. Sodium levels are high or low or normal?
Low.
Low.
Sodiums
Low.
are low.
Low.
Very low.
Potassium is high or
High.
low?
High.
High.
Potassium
Potassium
high.
is high.
High.
Little bit high.
Okay. In aldosterone, if aldosterone is high, what will happen to the potassium levels?
Will decrease,
It will
reduce.
decrease.
Okay,
Yeah.
but in our case, the potassium is high, right?
Mm-hmm.
Yes.
That
Mhm.
means that the aldosterone is
Low.
Low.
aldosterone
It
is
will
low.
be low.
Low. So option number E, option number D, option number C, and option number B are eliminated. We are left with A and F. Okay.
Yeah.
Okay. So Aldosterone is less in which disease?
Hypo.
Addison disease.
In Addisonian disease, primary adrenal insufficiency, right? In the primary adrenal insufficiency. Okay, in that you are going to see hyperkalemia, hypotension, okay, and the most common cause of disease is
Autoimmune.
what
Autoimmune
is
in
the
developed country and tuberculosis in underdeveloped countries.
and
Autoimmune disease. Yeah, autoimmune in the developed countries and in developing TB.
Infection, TB.
okay, adrenal insufficiency. Okay, first see the symptoms of adrenal insufficiency: weakness, fatigue, orthostatic hypotension, salt cravings, muscle aches with weight loss. Our patient has weight loss, right? Our patient has salt cravings, right? Our patient has orthostatic hypotension, right?
Correct.
Right. Okay. Now comes to the adrenal insufficiency. In primary adrenal insufficiency, what will happen to the cortisol? It is low. What will happen to the aldosterone? It is also going to be low. There is going to be hypotension. There is going to be hyperkalemia, metabolic acidosis. Okay. Okay, caused by atrophy. Most Addisonian disease most commonly due to autoimmune adrenalitis in high income countries. Okay, in US, the most common cause is autoimmune. Okay, that's why he has mentioned that her father, that the patient's mother and sister have hypothyroidism. This is a clue to indicate that the patient should also be have some type of autoimmune condition. Okay, and we know that the most common cause of primary adrenal insufficiency is an autoimmune condition. Okay, that's why whenever there is an autoimmune condition in the question, he will give you some clue that the patient brother or sister has vitiligo, has Hashimoto thyroiditis, has grave disease. He will give you some clue that the patient has a family history of autoimmune diseases. Okay, you will notice this pattern. Okay, whenever the diagnosis is an autoimmune condition. Okay. Okay, so what will happen to the cortisol? The cortisol will be
Reduced.
Reduced.
cortisol will
Low.
be reduced. Cortisol will be reduced. So F is also not the right answer. The only option that is left is option number A.
Yeah.
Primary adrenal insufficiency, history of autoimmune disease, Hashimoto thyroiditis. Okay, C. Renal cortex, reduce hyperkalemia. Okay, the hypovolemia that will causes the stimulus for the ADH. Okay, because the norepinephrine is also going to be high. Okay, which of the following is most likely which of the following is most likely a, responsible for the findings seen in the graph? Okay, with the options.
Please, what's wrong with this doctor?
Mute who is speaking.
Dr. Hosni.
Yes, I'm trying to find out the voice is coming from where.
I think it's coming from Dr. Lama's side. Rahanana, please.
Okay,
Check it.
Rihanna. I am mute the Rihanna. Okay.
That was
Okay.
DL Lama's mic.
It was not of Rihanna.
No, the previous one was not Rehanna. It was Lama. DL.
It was both of them.
Okay. Okay. I accidentally mute Rihanna. I don't know how to unmute it. Okay, sorry, Rihanna, I accidentally muted you and now I do not know how to unmute you. Okay, sorry. Okay, let's come back
Okay.
to the question. 60-year-old woman is being evaluated for chronic weakness and fatigue. Other medical problems takes no medication. Okay, after performing initial laboratory test, the physician decides to proceed with a meteoropon stimulation test. The changes in the urinary 17 hydroxycorticosteroid excretion following meteropon stimulation are shown in the following. Which of the following mechanism is most likely responsible for the finding in this patient? Okay. I have noticed they have removed many things from the new first aid. They have also removed the meteropon stimulation test from the new first aid 2025 variant. It was written in the 2024 variant 2023, but they've removed it from the. Okay, do you know, say, meteropon inhibits where?
It inhibits the 11-deoxycortisol conversion to cortisol.
It inhibits the conversion of.
11-deoxycortisol to cortisol.
Okay, so
Yes.
it inhibits the conversion of 11-deoxycortisol to the cortisol. Okay, so if you inhibit this, what will happen to the ACTH levels? If you give the patient meteropon and there is no more cortisol production, what will
Increase the
happen?
ACTH.
ACTH will be increased.
ACTH will be increased, CRH will be increased, right? Right?
Yes.
That means that the pituitary gland is working normally, right?
Yes.
Yes. And due to which we are going to see increased level of 17 hydroxyprogesterone, right? Because the enzyme is blocking here. It can block the conversion of 11 deoxycortisol to cortisol. Okay, the meteropon blocks this conversion. Okay, in the previous variants of the first aid, you can see there is meteropon written here, which is blocking this. Okay, in the 2024 variant of first aid. Okay, but they have removed it from 2025. I do not know why. Okay, because this test is no longer used, that's why I think so they have removed this. Okay, so all the things which are before this are going to be increased. Okay, because you are going to see a continuous stimulation from the ACTH surge. Okay, because ACTH is because the pituitary is detecting no cortisol, and due to which he is going to produce large amount of ACTH, and ACTH is going to continuously stimulate the adrenal cortex to produce the cortisol. But there is an enzyme inhibited here, due to which the conversion is not happening, but all the other precursor molecules like the 11 deoxycortisol, 17 hydroxyprogesterone are going to get elevated. Okay, so they are going to get increased. Okay, and this increase is due to what? What would be the right answer here?
ACTH.
ACTH surge.
ACTH surge. Okay,
Mhm.
it is going to be ACTH. Okay, see this. See this photo. In a meteropon inhibits the secretion conversion of 11-deoxycortisol to cortisol. A cortisol will be less, and due to less cortisol, what will happen? The CRH is going to be increased, ACTH is going to increase, which is going to stimulate the adrenal cortex to produces to try much harder to produce the cortisol. Okay, but due to which we are going to see increased level of 17 hydroxy progesterone levels, 17 hydroxy corticosteroids level. Okay. 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 Which of the following findings are most likely to be seen on autopsy? Okay, there is a 35-year-old woman. There is appetite loss, fatigue, weight loss, abdominal pain. Okay, the patient undergo upper gastrointestinal endoscopy, after which the patient develops cardiovascular collapse and dies. Okay, on autopsy, there is increased pigmentation around the nipple areola and the anal and vaginal mucous membrane. Okay, is the ACTH is high or low in this patient?
Hi.
High. High.
High. Okay, now tell me whether the aldosterone and cortisol, see the symptoms in this patient and tell me, are these symptoms of high cortisol or low cortisol or high aldosterone or low aldosterone? Tell me.
Low
Adrenal
cortisol.
insufficiency.
Yes.
Yeah, these are
Yes.
these are not the symptoms of high cortisol, right?
Yeah.
There is appetite loss, fatigue, weight loss. These are not the symptoms of high cortisol. Okay, so that means that the patient has adrenal insufficiency, and due to which we are seeing increased ACTH, and due to that increased ACTH, we are seeing increased pigmentation. Okay, so why does the patient dies here? What happened here? Adrenal crisis. This condition is called adrenal crisis.
Right.
Why does the what is the precipitating factor here which is leading to the adrenal crisis?
Stress.
The endoscopy.
The endoscopy. The precipitating factor is the endoscopy. It increases the stress on the body, but but because the adrenal glands are no longer be able to produce the hormones for the increased stress on the body, the patient goes into shock and the patient dies even with the aggressive resuscitative measures. Okay, this is called adrenal crisis. Okay, when also called acute adrenal Addisonian crisis, often precipitated by acute stressors. In our case, the acute stressor is endoscopy that increase the glucocorticoids requirement in patient with pre-existing adrenal insufficiency. Our patient has increased ACTH, which is indicating that the patient has a pre-existing adrenal insufficiency. Or on glucocorticoid therapy, our patient has acute abdominal pain, right? Our patient has nausea, vomiting, right? Altered mental status and shock. Okay.
What page number is that, doctor? I'm sorry.
On page number 353, acute
Okay, thank
adrenal
you.
insufficiency.
Okay,
Okay.
thanks.
Addisonian crisis. Okay.
Mm-hmm. Okay.
Okay. So, what would be the answer here? Option number B would be the right answer for what diagnosis? Bilateral adrenal hemorrhage.
Waterhouse
What
Frederickson.
Frederickson Waterhouse syndrome?
Yeah.
Yes,
Because of
Waterhouse.
yeah.
Meningococcal.
Yes,
Yes.
meningococcal infection.
Yeah, it is for Waterhouse Frederickson syndrome, but our
Right.
patient does not have a Waterhouse Frederickson
Waterhouse
syndrome.
effects.
Okay, so ischemic anterior pituitary necrosis. What is the diagnosis for
The
is-
Apoplexy.
This is the
Apoplexy,
detectable
it's
especially
the
apoplexy.
Sheehan
Sheehan
syndrome,
syndrome.
it
yes.
is
Sheehan.
Sheehan syndrome, not
Hmm.
apoplexy. In
Apoplexy.
apoplexy, there is hemorrhage.
Hemorrhage.
Hemorrhage, yeah, yeah.
Okay, in Sheehan, you are going to see ischemic infarct.
Hmm.
Option number D, large pituitary tumor with hemorrhage.
It
That
is the apoplexy.
This
This
is
one is
apoplexy,
the
yes.
apoplexy.
It is the apoplexy, yeah.
Okay, now tell me which one is going to be the right answer. A or
A.
A.
While atrophy of
is
both
atrophy
adrenal
of both
glands.
adrenal glands.
Yes.
Okay, because it is acute adrenal insufficiency. Okay, not adrenal hyperactivity. Okay, primary adrenal insufficiency, hyperpigmentation, acute adrenal crisis. The patient goes into confusion and shock. Okay, okay. The patient also requires immediate treatment with which of the following. Okay, see the options. Okay, now see the question. Okay. There is a 20-year-old woman brought to the emergency department, vomiting, abdominal pain. Okay. Anorexia, weight loss. Okay. Well controlled primary hypothyroidism. Okay. So you are seeing the pattern here. The patient has well controlled primary hypothyroidism. Okay. Eh, has not taken her medication for 2 days because of vomiting. Okay. Temperature is 37.6, blood pressure is 80 by 40. The patient is in shock, right? Okay, mildly lethargic but orientated. Generalized hyperpigmentation is present. ACTH level are going to be high or low?
Hi.
Hi.
High.
Hi.
Okay. Okay. Finger stick blood glucose is 60. 1 liter of bolus of normal saline is rapidly infused and high flow and intravenous fluids are continued. The patient also requires immediate treatment with which of the following? Okay. Does the patient's cortisol levels are high or low in this patient?
Low.
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 So,
The patient has adrenal insufficiency.
Insufficiency.
There's a what is the glucose value? 60. Okay,
50.
if we in hypercortisolism we are going to see high cortisol value, a
And BPL
high glucose values. Okay,
Yep.
and the abdominal pain and the vomiting and the weight loss, all of
blood
these are
pressure.
adrenal insufficiency symptoms. And
Mhm.
he has also mentioned that the patient has primary hypothyroidism. Okay, that is a clue that it is related to some type of autoimmune condition. And we know the most common cause of primary adrenal insufficiency is autoimmune. Okay,
Automatic.
so when we know when the stress increases in a primary adrenal insufficiency patient, a, it can lead to adrenal crisis, right? And the patient in this goes into the adrenal crisis. That's why the patient goes into shock. Okay. So now, along with the fluids, what other thing we have to give this patient?
Dopamine, I think. Oh, sorry, epi.
steroids.
Epi or dopamine.
Steroids. Because there is adrenal insufficiency and the body is no longer able to produce the steroids, the cortisol and the cortisol and the aldosterone. Then the other thing which we need to give in this acute adrenal
Epi.
crisis patient is
Epi, I
dexa
think.
dexamethasone.
Oh, really? Okay.
Okay, dexamethasone. Okay, because the main deficiency is of adrenal hormones, and to compensate for that adrenal hormones, we know cortisol is a steroid. Okay,
Mm-hmm.
and dexamethasone is a steroid. Okay, it is a Addisonian crisis patient, and the patient has a primary coronary primary adrenal insufficiency, severe hypotension, requires immediate glucocorticoid supplementation. Okay, planet adrenal hemorrhage. Addisonian disease. Treatment: glucocorticoid plus mineralocorticoid replacement. Okay, plus minus mineralocorticoid replacement. Okay, we have to give a glucocorticoid plus minus mineralocorticoid, because every glucocorticoid has within itself a mineralocorticoid activity as well. Okay.
Yes.
And dexamethasone have both mineral as
Yes,
well as
yes.
glucocorticoid.
Dexamethasone has both a
Both.
mineralocorticoid and glucocorticoid activity. Okay. Hydrocortisone has only, I think so.
Glucocorticoid only.
Yes. Which of the following laboratory findings is most likely present in this patient? Okay. Let's first try to diagnose this patient. See all the abnormal findings in this patient, and then try to make a diagnosis in this patient. 30-year-old woman is evaluated for a 3-month history of progressive fatigue, decreased appetite, and weight loss. Okay, decreased appetite, weight loss. Okay. The patient has type 1 diabetes mellitus. Okay, type 1 diabetes mellitus. Diabetes mellitus is an autoimmune condition, right? Type 1. She has no other
Yes.
medical condition. Generalized increase in pigmentation. Generalized increase in pigmentation. Okay, what ACTH is going to be high or low?
Yeah,
High.
hi.
Hi.
Yes.
High. Okay, measurement of
Melanin
serum
stimulating
cortisol.
hormone also.
Measurement of serum cortisol before and after the administration of exogenous a, a exogenous ACTH shows no difference in the levels. Which of the following changes? Does the patient has high cortisol symptoms or low cortisol symptoms?
Low cortisol.
Low
Low
cortisol.
insufficiency.
Okay. Okay. The progressive fatigue, decreased appetite, weight loss, all of these symptoms are of low cortisol. And we know low cortisol occurs in which disease? Primary adrenal
Primary
insufficiency.
insufficiency.
And he has also given the clue that the patient has
Autoimmune.
type 1, yes, as
One
an
of the autoimmune disease.
autoimmune. And the most common cause of primary adrenal insufficiency is
Autoimmune.
autoimmune condition. Okay, now comes to the question. Okay, if there is low aldosterone, low cortisol, what will happen to the potassium levels?
High.
Hi.
Potassium levels are going to be high. Okay, A is eliminated, C is eliminated, and E is eliminated. Okay. What we are going to see metabolic acidosis or metabolic alkalosis?
Acidosis.
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 Bicarb will be low.
So bicarb will be low.
Low. Yeah.
Okay. Is that acidosis is increased anion gap or normal anion gap?
Normal.
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 Normal anion gap. So the bicarb, so the chloride will be high. Okay. And what will happen? We have left with only one option. So this is going to be
No, this low.
B. Let's move on to the next one. See, symptoms are from fatigue, salt cravings, hyperkalemia, metabolic acidosis. Okay. And hypotension, hyponatremic volume contraction. Sodium will be low. Okay. Let's come back to the question. Biopsy of this patient's thyroid is most likely to show which of the following findings. See the option. Okay, we have to diagnose the patient and then we have to tell which of the following biopsy finding is consistent with the diagnosis. Okay. Okay, so the patient is a 51-year-old patient, woman, which is worsening fatigue, weight gain, and constipation. Okay, difficulty performing daily activities due to fatigue. Okay, okay, blood pressure is a little bit low, pulse is low, mild diffuse enlargement of thyroid gland. Okay, there is goiter there. Cardiopulmonary abdominal examination is normal. Okay, does the patient has hypothyroidism or hyper?
Hypo.
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 Hypo. Okay.
Hypo.
Hypothyroidism. Okay. And hypothyroidism is name 3 diseases in which you are going to see hypothyroidism.
renal thyroiditis, and
Hashimoto.
Hashimoto's.
And
Hashimoto, riddles,
decovariant
and
thyroiditis.
decurrence.
Defense.
Okay, okay. Option number A, branching papillae with cells containing empty or pairing nuclei.
Papillary
Okay, that is papillary cancer.
carcinoma.
Okay, in papillary cancer, we are not seeing hypothyroidism, right?
Yeah.
Thyroid values are normal in papillary cancer. Okay. Follicular hyperplasia with tall cells projecting into the follicular lumen.
Graves.
Graves disease.
That is,
Graves.
it is not
Graves.
follicular
Graves.
carcinoma, it is
It's
Graves.
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 It's
Graves.
Graves.
Okay.
Tall cells. Yeah.
Okay. So
Tall cells.
until or unless the follicular cells invade the vasculature or the capsule, you cannot say it is a follicular carcinoma. Okay, and we know that there in the Graves disease there is scalloped colloid, and that due to which there is invagination within the thyroid follicles. Okay, and then the cells project within the follicular lumen. Okay, so that is Graves, and Grave is hypo or hyper. Grave is
Hyper.
hyper. And
Hyper. Hyper.
hyperthyroidism.
Mm.
Okay. Widespread inflammatory infiltrates giant cells and disrupted follicles. Giant cells are
Granulomas.
seen in what? Giant cells.
Decurrence.
Yes, it is
Decurrence.
yes, it is decovariant because multinucleated giant cells are seen in granulomas, and we know the granulomatous inflammation is seen in what? In
Tuberculosis.
decovariant thyroiditis.
Hmm.
Decovariant thyroiditis is hypothyroidism or hyper?
Hypo.
Hypo.
Hypo. That is hypo.
Initially first
But
higher, then
yes,
low. Hypo.
but in our patient, is he mentioned that the patient has an early flu-like illness, or is he mentioned the patient has a tender thyroid?
No.
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 Okay. Okay. Now we are left with B and D. Option number B.
That's radio. Radio.
That is
Reduced
renal
B is the
thyroiditis.
yes.
Okay.
B
Okay. And in renal thyroiditis, we are going to see a hard and fixed thyroid. Okay. Often resembling a malignancy, not a diffusely enlargement thyroid gland. The goiter a is not in the readers. Okay. So option number D, intense plasmacytic infiltrate with active germinal centers. That is present in what conditions?
Hashimoto.
In Hashimoto thyroiditis. And Hashimoto thyroiditis is hypo or hyper?
Hypo.
Hypo.
Hypo. Okay, very good. Let's move on to the next one. Let's see the option. Okay. Okay, there is a 27-year-old man, recurrent episode of muscle weakness. Okay, no the significant weakness. Blood pressure is very high. Okay, rest of the physical examination is unremarkable. Plasma renin levels are low. Overactivity of which of the following is most likely responsible for this patient? Renin is involved in the regulation of what hormone?
Aldosterone.
Aldosterone.
Aldosterone. Renin is involved in the regulation of aldosterone hormone. Okay, muscle weakness and hypertension. Our
Hypokalemia.
patient has two signs and symptoms: muscle hypertension and muscle weakness and low renin. Is the aldosterone going
Hyperaldosteronism.
to yes hyperaldosteronism? There because that can explain the hypertension, and the muscle weakness can be explained by the
Hypokalemia.
Hypokalemia. Okay, the muscle weakness. Okay, so okay, now tell me, is the hyperaldosteronism is primary or secondary here? The renin is low.
Primary.
Primary.
Primary because renin is low. Primary.
Yeah, it is
Primary.
because same like the if the high cortisol is due to a primary pathology, ACTH is going to be low, and if it is due to secondary, ACTH is going to be high. Same in this case. If it is due to primary, renin is going to be low, and if it is due to a secondary pathology, then the renin is going to be high. And in
High.
our case, renin is low. That means it is a primary hyperaldosteronism. Okay. Aldosterone is produced by what layer of the adrenal cortex?
Glomerulosa.
Yes. Remember the mnemonic GFR,
Yes.
glomerulosa. The outermost layer produces what hormone? The aldosterone.
Aldosterone.
Okay. Primary hyperaldosteronism seen in patient with bilateral adrenal hyperplasia. The other name is Cone syndrome as well. We are going to see high aldosterone and low renin. Okay, leads to treatment resistant hypertension which is present. Okay, okay, okay. Let's move on to the next one. The tumor cells are functionally similar to the cells from the outermost hormone producing layer. What is the name of the outermost layer of the adrenal cortex?
Granulosa. Granulosa.
Granulosa. Granulosa. And what hormone is produced by the granulosa?
Aldosterone.
Okay, in aldosterone.
Mineralocorticoids.
Oh, yes. And in aldosterone, what will happen to the potassium? Primary hyperaldosteronism.
Low potassium.
Low.
Okay. Which of these
Low.
symptoms of low potassium?
C.
C.
Muscle weakness because of hypokalemia. Paralysis.
Option number D is the symptom of.
Pheochromocytoma.
You can say pheochromocytoma or hyperthyroidism.
Yes.
Option number E is the symptom of.
Cortisol. Hypercortisolism.
Cushing's.
Excessive hair growth.
Cushing syndrome.
Excessive hair growth is a symptom of.
Also Cushing's.
Excessive hair growth can be seen in increased androgens. Okay, hirsutism.
Hirsutism. Yes.
Okay. Okay. So our this block is finished. After this, we are going to start now a pharmacology. Okay. Now I'm going to make a block of pharmacology, and we are going to start pharmacology. Okay. Okay. Just give me a minute.
Sorry, sir, I have a question.
Yes.
In your world, we have mixture of, I think it's system-wise. The anatomy, physiology, pathology, and pharmacology is mixed. From where you start the just pathology block and just pharmacology block?
You can select the just it's first select endo, and after selecting the endo, you can select the just pharmacology question. Like before selecting the system, you can select the subjects. Okay, there is an option in the
Okay, okay. Thank you so much.
okay, like there are 51 questions of pharmacology here. I need to make a block of 21, 10. Okay, 10 questions here. Okay, this two. Just give me a second. Okay. Here is the option of stores. Okay, so these are the questions of the pharmacology. There are 51 questions of the pharmacology. Okay, so these are the first 40 questions. Okay, let's start. Which of the following is most likely occurred in this patient as a result of the medication use? Two. 52-year-old post-menopausal woman comes to the office for a follow-up appointment 6 months ago. The patient had brief episodes of excessive warmth and sweating, which were interfering with her usual activity. Thyroid hormone levels are normal. Patient was subsequently diagnosed with menopausal hot flashes. Treatment with estrogen-containing hormone replacement therapy was begun. Okay. How does estrogen affects the thyroid levels? Okay. How does the estrogen affects the thyroid levels? Okay. What will happens to the thyroxine binding
Increases.
globulin? The
Increase.
thyroxine binding globulin would be increased.
Increase, yes.
Okay. Thyroxine binding globulin. Okay. The bound thyroxine
Oh,
is
wow.
going to increase. Okay, the bound thyroxine is going to increase. Okay, so there are two types of thyroxine which are present in our bloodstream. One is free thyroxine, which is not bound to the thyroxine binding globulin, and the other is bound thyroxine, which is bound to the thyroxine binding globulin. Okay, the active thyroxine is the one which is free. Okay, if we are going to see any change in the free thyroxine, we are going to detect any change in the TSH activity as well. Okay, when we say that the patient has hypothyroidism, we are saying that the patient has low free thyroxine. Okay, When we saying the patient has hyperthyroidism, we are saying the patient has high free thyroxine, because the free thyroxine is the one which is metabolically active. Okay. Okay, let's open page number. Specific globulins. Okay, thyroxine binding globulin binds most T or T4 in the bound T3 and bound T4 is inactive form. Okay. Thyroxine binding globulin is going to increase in pregnancy and OCP use. Okay, increase TBG. Okay. Okay, when you are going to, in our patient, the patient is taking what? Hormone replacement therapy, estrogen containing hormone replacement therapy. What will happen to the TBG? It is going to be
Increase.
increased. TBG is going to increase. So the bound thyroxine is also going to
Increase.
bound thyroxine is also going to increase. Total thyroxine, what will happen to the total thyroxine? Total thyroxine is equal to bound thyroxine plus free
Free.
thyroxine.
Free.
Okay, bound thyroxine is also going to, a total thyroxine is also going to be
Increase.
increase. What will happen to the free thyroxine?
Decreased.
The free thyroxine is going to be normal. There, you are not going to see any change in the free thyroxine. Okay, free thyroxine is going to stay the normal.
Due to
Bound
negative.
thyroxine is going to elevate it, and the total thyroid hormone within the bloodstream is also going to be elevated. What will happen to the TSH levels?
Decrease.
Increase.
Yes, true.
Because
No.
negative feedback.
There is
Increase.
no.
it will decrease.
Initially,
I have told you,
No, it is normal.
Normal.
TSH levels are controlled by what thyroxine hormone? Bound or free?
By free time.
Free.
Free time.
By
Free.
the free,
Free
the
T3.
active one, the free thyroxine. TSH are controlled by the free thyroxine. And in this patient, the free thyroxine is going to be normal. So the TSH is also going to be normal.
No.
Normal.
Okay.
No symptoms.
Okay. Okay. So, which free T3 levels are going to be option number D. Free T3 levels are going to be high, low, or normal. They are going to be
Free T3 will be low.
Free. T3.
free T3 is going to be normal.
No.
Okay.
The free one is not
Only
going to
only
change.
total will decrease, otherwise everything
Only
will be normal.
the total T4 and total T4 and total 3 are going to be increased.
Okay.
Okay. And why the total is increased? Because total is equal to bound thyroxine plus free
Free
thyroxine.
thyroxine.
And increase by giving estrogen, thyroxine binding globulin is increased, and the bound thyroxine is going to be increased. So bound is increased, free is going to remain the same. Okay, so that's why the total is going to jump. Okay, because the bound is increased and T3 is staying remain the same. Okay, because if the free is increased or decreased, you are going to see the symptoms of hypo or hyperthyroidism. Okay, but did you ever see symptoms of hypo or hyperthyroidism in patient taking estrogens or contraceptives?
No.
No. Why? Because the free does not change. Free does not depends upon estrogen. Okay? Only the bound is dependent on the estrogen. And the bound is an inactive form. And the free is the active form. Free is the one which causes the hyper and hypo symptoms, which regulates the TSH levels. Okay?
And
So
same happen in pregnancy.
okay. So T3 is going to be, free T3 is going to be normal. What will happen to the TSH levels?
Normal.
They are
Normal.
also
Also,
going to
we
be
know.
normal. They are also going to be normal. Estrogen does not affect the conversion of T4 to T3. Thyroid iodine uptake is not going to be affected. So the right answer is going to be
Increase total
E.
T4.
increase total T3. T4. Our free T3 free normalize as the appropriate quantity saturated.
The option B, sorry, the option B can be seen where?
Option number B.
Yeah, decreased thyroid iodine uptake.
Yes, because there is a temporary increase in the thyroid uptake, and after some time it is also going to be normalized. Okay, because when the TBG is increased, it requires new thyroxine hormone to bound itself. So due to which there is going to be a transient increase, but that will also going to be normal after a few minutes or after a few hours. Okay. Okay. Okay, the patient is treated with drugs getting Okay, a 35-year-old woman comes to the emergency department due to a racing heart, shortness of breath, she has insomnia. So the patient has symptoms of hyperthyroidism, and we started the patient on propranolol, which is a beta blocking drug. Other than the receptor beta-adrenergic receptor blocking activity, which of the following is also a function of propranolol?
It prevents the
Peripheral conversion of T4 to T3.
Peripheral conversion of T4 to T3. DIP. Peripheral conversion is inhibited by glucocorticoids, beta blockers, and PTU. Which three drugs block the peripheral conversion? Glucocorticoids, beta blockers, and PTU. Okay, remember this. Okay, so PTA. So the beta blocker prevents the peripheral conversion of T4 to T3. Okay. Binding of T3 to its receptor, new thyroid hormone synthesis. Which of the following should be started in this patient? Will be started in this patient.
Is Skylar here yet?
Okay, let's see the option. Now see the question. 42-year-old woman with Graves' disease is hospitalized for elective total thyroidectomy. Her hypothyroidism symptoms are being normal. We have been controlled with methimazole and propranolol. Okay, the patient has no other medical problems. He undergoes total thyroidectomy without any immediate operative complication and feels well the next day. Sodium is 141, potassium is 4.4, creatinine is 0.8, and the calcium is 7.5. Preoperative electrolytes values are within normal. Which of the following should be started in this patient? Okay, the patient has elective total thyroidectomy. She undergoes total thyroidectomy without any complications. Okay. What is the calcium levels are normal here?
It's
Low.
low.
It is
Low.
low.
Calcium
Hypocalcemia.
levels are low. Why the calcium levels are low here?
Because of hypoparathyroidism. That's
Hypoparathyroidism.
also developed.
And why the patient has hypoparathyroidism here?
Because of surgery of
Surgical
thyroid.
removal.
Because of the surgery.
Maybe the remover.
Yes. Because the patient underwent total thyroidectomy, and during the thyroidectomy surgery, the patient removed the parathyroid glands as well, because parathyroid glands are located with the on the sides of the thyroid gland, and sometimes we also have to remove the parathyroid because the cancer has infiltrated the capsule of the parathyroids as well. Okay, so now which of these hormone is going to increase the increase the calcium levels?
Calcitone. Calcitriol.
Calcitriol. Okay,
Triol.
calcitriol is vitamin D,
D.
active form of vitamin D. Okay, and it is going to increase the calcium level. Not radioactive iodine, not prednisone, not alendronate, not cinesulate. Okay, calcitriol. It is the active form of vitamin D. Okay, it will increase the calcium levels. Hypoparathyroidism, calcitriol. Okay, very good. Okay, prolactin is 332. Which of the following are changes are most likely to occur in the first weeks following initiation of therapy? Okay. Three-month history of dull, aching, daily headaches, and peripheral vision loss. The patient has no chronic medical conditions, bilateral gynecomastia, bitemporal hemianopsia, creatinine is 1.2, TSH is 1.1, cortisol is 12, prolactin is 332. MRI reveals pituitary macroadenoma. So a therapy is prescribed. Which of the following? Okay. So this drug acts like this drug acts like dopamine. Right?
Dopaminergic agonist.
Yeah, it is a dopamine receptor agonist. Okay, and we know dopamine is a inhibitor of prolactin, right? Prolactin is decreased by dopamine, right?
Dopamine.
Right. So what will happen to the serum prolactin levels?
Decrease.
They are going to decrease.
Decrease.
Okay. Okay. Prolactin causes erectile dysfunction. How?
Prolactin decrease erectile production.
Because it decreases the GnRH levels, and through which it decreases FSH, LH, and eventually testosterone is going to decrease. That causes the erectile dysfunction. Now, when we have started this medication, what will happen to the erectile dysfunction? Is it going to improve, or is it going to no change?
Improve.
Improve, because now the GnRH value levels are going to come back to the normals. Visual field defects. Once the patient has a pituitary macroadenoma, once the stimulation of the cells have been reduced and the cells are no longer going to produce prolactin, does the cells are going to atrophy or hypertrophy, or are they are going to show no change?
Improve because the treatment has been started.
Yes, because now the cells are starting to get atrophy. prolactin. Dopamine agonist inhibits the cabrogalaline, you can clearly see inhibits prolactin secretion and can be used in the treatment of prolactinoma. Okay. Okay, and in this way, are they going to improve the condition? Dopamine inhibits the secretion of prolactin. Okay. Which of the following potential complications should be considered? Okay.
Okay, she prescribed cannot give renal following essential complications to be just but that it is
Okay, so what medication we have started in this patient?
it is
We started canagliflozin.
SGLT
Canagliflozin.
SLG.
L2 inhibitor. What is the mechanism of action of canagliflozin?
It blocks
prevents
glucose
It increases the LGL2 in the proximal renal
Yes, it
tubule.
blocks the SGL2, a sodium glucose co-transporter, and decreases the reabsorption of the glucose within the kidney tubules. So we are going to see increased urine, increased glucose within the urine. Okay. Lactic acidosis. Lactic acidosis is complication of which anti-diabetic medication?
Metformin.
Metformin.
Metformin. Hypoglycemia. Medication, anti-diabetic medication. Sulfonylureas or insulin.
Insulin.
Okay. Fluid overload. Fluid overload. Heart failure. Fluid overload, heart failure.
Higher
Which
glucosomes, maybe?
by yes, thiazolidinidones.
Gingerls, yeah.
Pioglitazone. Okay, pioglitazone. Okay. Weight gain is the side effect of which anti-diabetic medication? Weight gain. Which
Insulin.
Insulin, sulfonylureas, and the pioglitazone as well cause the weight gain. Okay, there are 2 to 3 medication which causes the weight gain. Okay. So what is the side effect of SGLT2? Vaginitis. Because there is now increased glucose in the urine, and due to that increased glucose in the urine, it will act as a it will increases the growth of the bacteria within the area, within the urinary tract. Okay, and the whole of the reproductive tract, due to which we are going to see increased UTIs, increased vaginitis, all of these infections are due to increased glucose in the urine. Okay, increased
And weight
glucose
gain by GLP-1, delayed gastric emptying. Sorry, A.
Yes. UTIs and vulvovaginal candidiasis. Okay, in SGLT2 inhibitors, canagliflozin. Okay, and weight gain, edema, fluid overload, heart failure, and weight gain occurs in which disease? Pioglitazone. Okay, we no longer use this medication. Okay. Which of the following mechanism is most likely to responsible for the improvement in this patient medication? See the question. First, tell me the diagnosis. What medication we use in this patient? Macrolide antibiotic. Okay, so the patient is suffering from what complication of type 1 diabetes mellitus? Patient has recurrent nausea, vomiting, upper abdominal discomfort after meals, and feels full after eating a small amount of
Yes.
food.
Gastroparesis.
Yes.
Autonomic neuropathic
Yes, the
gastroparesis.
patient is suffering from gastroparesis. Okay, he also has experienced several episodes of vomiting of undigested foods, but has no fever or diarrhea, type 1, diabetic neuropathy, bowel sounds are normal, stool testing is normal, endoscopy is normal. Okay, so the patient is suffering from gastrointestinal endoscopy. A macrolide antibiotic is prescribed which improves her symptom. Do you know the name of this medication? Which increase
Erythromycin.
Erythromycin.
erythromycin can improve the gastroparesis symptoms.
Prokaryotic.
Yes, commonly
Oh.
used in ICU.
So pharmacologists, macrolides, gastrointestinal motility issues can be treated with azithromycin and erythromycin. Okay, they can be used in gastrointestinal motility issues as well. Okay, so how are they going to improve the gastrointestinal motility?
Activating a motility receptor.
Direct
By-
release activation of motor receptor and the GIT.
by working as an agonist activity on the motilin receptors. Okay, they are going to improve the gastrointestinal motility issues, the gastroparesis here. Okay. Okay, protective effect, irritable bowel syndrome, dicyclomine, peptic ulcer disease is used in gastric mucosa. Okay, okay, examine. Diabetic gastroparesis, erythromycin is used as a prokinetic effect. Let's move on to the next one. Elevated C-peptide levels. You can make sure the following.
Glyburide. Yes.
So now see what are the symptoms? What are these symptoms? Confusion, lethargy, disoriented or weak. The patient is monolith.
Hypoglycemia.
Diabetes.
What are these symptoms? All of these symptoms are due to what?
In
Due to
insulin
hypoglycemia.
level.
Due to
Hypoglycemia, yes.
hypoglycemia. Okay, now we have to tell why there is hypoglycemia symptoms here. Okay, and and he has given us one clue that the C peptide levels are elevated. We have to tell which of the anti-diabetic drug is it. Okay.
Sulfonylurea.
Okay.
Sulfonylureas.
Okay. Why not G is the right answer? If I say that he is using short-acting insulin also causes hypoglycemia. Why
No
not?
CP.
But that is
Yes.
exogenous
Peptide.
source. That will be then exogenous source
Yes,
of
exogenous.
Yes. Yes, because the C peptide levels are elevated, and we know that C peptide levels are elevated in endogenous insulin. If we are taking insulin from outside the body, that insulin does not contain C peptide with it. So that's why G is not the right answer, even if it causes hypoglycemia. In this case, the cause of hypoglycemia is not the abuse of insulin, but the abuse of sulfonylureas. Which one of these is a sulfonylurea drug?
glyburide. Glyburide.
Right.
Glyburide.
Yes.
Glyburide.
Laborate.
And we know that glyburide do causes hypoglycemia, right? Sulfonylureas, they causes hypoglycemia. Okay? Glyburide. Okay. Okay. Sulfonylurea. Hypoglycemia can also be seen in these diseases. Very good. Let's move on to the next one. The medication most likely responsible for this patient and symptom was by targeting which of the following. Headache, nausea, sweating, a feeling as if she is going to pass out. 3 such episodes in the past 2 weeks, with symptoms occurring when she skips a meal. Finger stick glucose was 50. Type 2 diabetes mellitus. 3, he was initially treated with metformin and glipizide and inadequate glycemic control. Okay, most likely responsible. Okay, the symptoms are due to what? What is the
Because
cause
of
of the symptom?
skipping meals, so hypoglycemia.
Skipping means
Due to
yes.
hypoglycemia.
Glycemia.
Okay. Out of the patient is using two drugs, metformin and glipizide. Which of these 2 drugs can cause hypoglycemia?
Glyphosate.
Glipizide. Glipizide is a sulfonylurea and it can cause the hypoglycemia. What is the mechanism of action of glipizide?
It blocks the potassium channel on the cell membrane and increase the intercellular calcium,
Yes.
which increase the
Yes. It
insulin
blocks what channel?
secretions. Potassium
The
channel.
potassium channels in the pancreatic beta cell depolarize, increases the insulin release, right? And it causes hypoglycemia. Okay. E would be the right answer for what anti-diabetic medication? A would be the right answer for what
E would
anti-diabetic?
be for insulin, I think.
Option number A. Option number A.
A. Okay.
E would be the right answer for insulin. Option number A would be the right answer for
Interesting.
Metformin.
metformin.
Yeah.
Very good. Metformin. Option number B.
Incretin receptors.
Thyroid.
Right.
Yes, thyroid.
It can be
Steroid.
Steroid.
Insulin.
And
Yeah.
thyroid.
Tell me the anti-diabetic medication.
Insulin.
Pioglitazone. Okay, pioglitazone. Okay, surface and
Oh yeah, receptor.
option number D.
Those.
Option number D. Anti-diabetic medication. Option number D. GLP-1 receptor agonist. Okay. GLP-1 receptor is an adrenaline cyclase receptor. Okay.
Where is it?
Okay. Let's move on to the next one.
The concentration of the pancreatic gland is measured after the administration of various agents.
Okay. In a series of animal. Okay. So by serum glucose, beta 2 causes the. Which of the following receptor does drug A most likely block? Okay. However, after treatment with drug A, epinephrine injection causes a paradoxical increase in insulin concentration. Okay. Okay.
Alpha 2
Which of the which of the receptor causes the which alpha and beta receptors causes the increase insulin secretion or decrease insulin secretion?
Increase insulin.
Alpha 2
Alpha 2
receptor.
decreases, inhibits.
Alpha 2 receptor decreases the insulin secretion, and beta 2 receptor
Increases.
increases the insulin secretion. Okay. Let's for this we have to go into the general pharmacology. Okay. First, see alpha 2 receptors. Okay. It decreases the insulin release. Alpha 2 decreases the insulin release. Now, see the beta 2 increases the insulin release. Okay. Okay. Now comes to the epinephrine. Okay. There's a, I forget where it is. Okay. Epinephrine. Epinephrines act on both beta and alpha receptors. Okay. Alpha effects predominate on the high doses, and and on the lower doses there is most likely beta effects. Okay. So in the question he has mentioned, we have given the patient a drug which blocks a specific receptor. Okay. And we know that epinephrine acts on two receptors, alpha and beta. And through alpha receptors it can decrease the insulin secretion, and through beta receptors it can increase the insulin secretion.
Increase.
And yes, and now after adding that drug, the we are seeing increased insulin secretion. So which of the receptor is going to be get blocked? The
Alpha
one
2.
which is decreasing the insulin secretion, that is getting blocked here, right? And we know which receptor block decreases the insulin secretion?
Alpha 2.
Alpha 2.
Alpha 2.
Okay. Alpha 2 decreases the insulin secretion. Okay. And epinephrine does not act on GLP-1, does not act on histamine, does not act on muscarinic receptor. It acts only on these two receptors, right? Alpha and beta receptors. And the receptor which is going to be blocked here, it is alpha 2, because that is the receptor which causes the decrease. And if we are going to block that receptor, we are going to see the increase. Okay. Okay. Which of the following finding is most likely to persist in this and despite this? The patient has symptoms of what? Hyperthyroidism or
Hyperthyroidism.
Exophthalmos,
Hyperthyroidism.
the patient has symptoms of
Graves' disease,
the patient has symptoms of hyperthyroidism, right? Okay. To treat the hyperthyroidism, what drug do we give?
blocker,
Methimazole, PTU,
After
and
after the
beta blockers.
diagnosis, yeah, we can give beta blockers and the
Beta
PTU
blockers.
and the PTU or the
Methimazole.
methimazole. Okay. So we know that all of these symptoms are going to get controlled. Which symptom cannot be get controlled by these beta blockers or anti thyroid drugs?
Exophthalmos, because it's through the hormones
Exophthalmos
directly.
is going to get controlled by what medication?
Right.
It is going to be get controlled by steroids.
Steroids.
Graves or betopathy treat with glucocorticoids. Okay, it is going to be treated with steroids. Okay. Not used to treat Graves' ophthalmopathy, treated with
Rahanani, please, can you mute yourself? You are distracting the class.
okay. Okay, and because Graves' ophthalmopathy can only be treated with steroids. That's why even after giving the methimazole or P2U or propranolol, we still cannot be control the symptoms of still cannot control the symptoms of exophthalmos. These symptoms can be controlled by what? By giving the patient steroids. Okay. C is the right answer. The newly prescribed medication most likely improve the patient's glycemic control through which of the following? Okay. Which drug is added?
Dipeptidase. Oh.
An additional medication that inhibits the DPP4. Okay, what does DPP4 does?
it deactivates the GLP-1.
Yes.
So increase the effect of GLP. Yes.
Okay, yes. DPP4 inhibitors will inhibit the degradation of GLP-1 analog, right? It will inhibit DPP4 is basically an enzyme that degrades what? GLP-1. Okay, and if you inhibit that enzyme, the degradation will be stopped. Okay, the liraglutide, the exenatide, all of these are. Okay, let me open the. Okay, DPP4 inhibitors. What is this mechanism of action? Increase the glucose dependent insulin release. It will decrease the glucagon release, decrease the gastric emptying, and increase the glucose dependent insulin release. What will be the answer here? What will be the answer here? Increase glucose dependent
insulin release.
Increase glucose dependent insulin release. Decreased renal glucose reabsorption. Name of the drug.
Closing.
GL2.
Closing.
Gluten.
Closing.
Increase dietary carbo. Option number A. Option number A. Name the drug. Option number A.
Okay, boss.
Yes. Option number A is एक का carbose. Okay. Alpha glucosidase inhibitors. Okay. Option number C. Option number C is GLP-1. It is not of any drug. Okay. And option number E is mainly for metformin. Okay. Which of the following when used as most likely to increase triglycerides levels in this patient? Okay. Which one of these can cause the increased tag levels in this patient? Lipid level in the last 10 years. Okay, which one increases the tag levels? For this, we have to go back. In February, see the tags. See, triglycerides decreased, slightly increased, decreased, decreased. There is only one drug in which there is a slight increase in the triglycerides. Which ones are they? The bile acid resins. Okay, and all the others lipid lowering drugs you are going to see decreased by a decreased tags. Okay, there is only one drug in which we are going to see increase. Okay, that is cholestyramine. Okay. Which one is going to be the right answer here?
Cholestyramine.
Yes.
B.
B. Cholestyramine. After the discussion with the patient, metformin therapy is initiated. Okay, we have to tell about the effects of metformin. How does metformin? Does metformin has any effect on the peripheral glucose uptake?
Yes.
No.
It increased sensitivity to
It has
Yes.
effect. It
No.
increases the
It increases the peripheral glucose uptake. It
uptake.
will
Yes.
increases the muscle glucose uptake, right?
Yes.
It increases the sensitivity of the tissues to the insulin. And by increasing the sensitivity, it means it increases the ability of these tissues to increase the uptake of the glucose from the bloodstream.
For muscles and adipose tissue.
And it also inhibits the hepatic gluconeogenesis. In peripheral glucose uptake is increased. Okay, insulin sensitivity is increased. Remember, insulin sensitivity is increased. Insulin is not increased. There is a difference between increasing the sensitivity and increasing the insulin. Okay, remember this difference. Okay, muscle uptake is increased. Hepatic gluconeogenesis, is it going to increase or decrease?
Decrease.
Decrease.
cholesterol 3-phosphate dehydrogenase.
What will happen to the endogenous insulin production?
Not affected. Unchanged.
Not affected, unchanged.
Yeah.
It is going to be unchanged.
Unchanged.
Insulin sensitivity is going to be increased. Insulin production is not going to be increased. Okay.
Doctor, what is it? Can I ask a question?
Yes.
When you, maybe I forgot, when you say the sensitivity of insulin, what does that refer to?
Sensitivity means that the cells, because the cells develop resistance to the insulin. Okay. And metformin increases the ability of the cells to respond to the insulin. That is what, when we say that insulin sensitivity is increased, that means the cells ability to respond to the insulin and then to uptake the glucose from the bloodstream, that is increased. Okay, that is what means that insulin sensitivity is increased. Okay.
Okay.
Which of the following
Thank you.
laboratory tests shall
Thank
be
you.
obtained prior to starting this medication? Okay. Pharmacotherapy with metformin is planned. Which of the following should be obtained prior to starting this medication?
Plasma lactate level.
Okay, which one should be made before starting metformin? What are the side effects of metformin?
A renal insufficiency.
Renal insufficiency and
What are the side effects? What
lactic
are the side
acidosis.
effects of metformin?
Lactic acidosis.
Lactate
Acidosis.
Vitamin
Okay.
B12
Okay, if it
deficiency.
is lactic acidosis, why not the C is the right answer? Why not C? C is the right answer.
Well, I think normally the lactic acidosis is
Normally there is,
mostly
yeah.
when
Yes.
Yes, it does not
Rare.
causes lactic acidosis in normal
Yes.
persons.
Yeah.
It only causes lactic acidosis in renal
Renal failure. Yes.
Okay, because in renal insufficient patient, the elimination of the metformin from the blood is going to be reduced. Okay, due to which the half life is going to increase, and due to which we are going to see lactic acidosis. Okay, in renal, so we are going to measure creatinine. Okay. Hepatic insufficiency, decompensated heart rate. Okay, let's see. Thyroxine is low or high?
Low.
Low.
Yes. So the patient is of the patient has congenital hypothyroidism. Oh, and for that we have started the patient on levothyroxine. Okay. So if we started the patient on levothyroxine, so the patient thyroxine should be normal, right? But we are seeing in patient that the patient thyroxine is still low. Why the thyroxine is still low in this patient, even when the patient is taking levothyroxine? What is the cause here?
thyroid hormone resistance.
Dietary. Um.
What is he
What is
taking
the
with
cause?
iron or what is taking to
Dietary
drugs?
cause, as the
Yes.
patient is also taking the vitamin D and the iron supplements, and these drugs I think are decreasing the activity of levothyroxine.
Okay, so
Maybe abnormal, maybe inadequate intake.
okay, so the main cause of why we are seeing
Not
the
absorption properly in the GIT because
yes,
the
because we are taking the
iron.
levothyroxine drug with the with vitamin D and iron supplements. Whenever we have to take levothyroxine drugs, we have to take the drugs. Never mix this drug with the iron supplements or calcium supplements or antacids, because they are going to affect the absorption of the levothyroxine. Okay. Now, because we are taking the supplements with vitamin D and iron supplements, the levothyroxine is no longer be getting absorbed. Okay, so that's why even when the patient is taking levothyroxine, we are seeing the symptoms of hypothyroidism. Okay.
The same with calcium, we have to
Yes.
avoid the calcium milk and the products when they're taking
Iron or
levothyroxine.
calcium
Yes.
supplements. It is written.
Sir, please, can you please re-explain? I didn't get the explanation you made. Please, thank you.
Avoid levothyroxine with antacids, bile acids, or ferrous sulfate. It decreases the absorption. When you are taking levothyroxine with these drugs, and in our case, the patient is taking the levothyroxine with daily vitamin D and iron supplements. And we know when we take the levothyroxine with iron supplements, what will happen? It will decrease the absorption of the levothyroxine, due to which in this patient we are still seeing the hypothyroidism symptoms. Okay, so we have to be always remain careful to not mix the drug with iron supplements or calcium supplements or antacids or bile acid resins. Okay. Okay, that's why we are seeing hypothyroidism. Am I being clear to you?
Yes, good.
Okay. Let's
Because
move on.
the levothyroxine is iodine is negatively charged, and the calcium antacid also there is magnesium and aluminium, iron. They have a positive charge. They attract each other and they decrease the reabsorption, the GIT.
Okay. Let's move on to the next one. So which drug we started in this patient?
Sodium glucose
Sodium,
transporter inhibitor.
glucose transporter
Okay.
inhibitor.
And which test we should do before starting the
I think urine analysis because it starts
Creatinine,
urinary
creatinine test,
antithesis.
creatinine test, because it's also given with caution in
use
the
with
renal
caution in renal
renal
insufficiency.
insufficiency.
Okay. A Because decreased GFR causes decreased efficacy.
We're not
Okay.
hearing him
As the
anymore.
SGLT2 inhibitors, yes, increases the urinary tract infection, but to do screening for these in a asymptomatic patient is unnecessary. Okay, that's why we do not do a urine analysis in SGLT2 inhibitors. Okay. Okay, in asymptomatic patients. Okay, in symptomatic patients we do the urine analysis, but in asymptomatic patients we do not do the urine analysis. Okay, before starting SGLT2 inhibitors. but we do the creatinine levels because the efficacy of the drug is dependent upon the renal insufficiency, upon the GFR. Okay, the lesser the GFR, the lesser will be the efficacy. So serum creatinine. Okay.
I have a question.
Yes.
Which medication side effect causes the euglycemic decay?
I think so. As SGLT2 inhibitors.
But it's not written in the first aid, but I saw a question asking
Yes,
that.
there's a question on this on your step 2 as well, and in step 3 you would as well. It causes euglycemic diabetic ketoacidosis. Yes, it is not mentioned in the first aid.
Okay, thank you.
It is not mentioned in the first aid. Which of the following is the most likely mechanism of action of this medication?
I'm sorry, what was that medication?
SGLT2 inhibitors.
What was the side effect?
Euglycemic ketoacidosis.
SGL1, right?
Yes.
Mm. Okay, thank you.
Okay, which of the following is the most likely mechanism of action of this medication? 29-year-old newly graduate woman comes to the Okay, so can anyone read the symptoms in this patient? What are the abnormal findings in this patient?
Galactoria,
Yes. Other than that, any other abnormality?
headache, vision, and there is no breast pain added. Binatural nephritis,
amenorrhea also last 3 months.
amenorrhea.
Secondary.
Or
Yes, amenorrhea.
other than that, and there is a pituitary mass as well.
Pituitary
Right?
mass, yeah.
Yes.
So what is the diagnosis here?
Yes. It's the adenoma.
Prolactinoma.
Prolactinoma.
This prolactinoma. So and we know to treat the prolactinoma, which drug do we give?
Ergoline and
Dopamine agonist.
Dopamine receptor agonist.
Agonist.
Okay, so which one should be the right answer here?
D.
D.
D would be the right answer.
yes.
Okay, the patient has prolactinoma, and we know dopamine agonists are used for treating the prolactinoma. Cabergoline.
And it's microadenoma, less than 1 centimeter is mostly treated by medical,
Yes.
Is from macro more than 1 centimeter, then go for surgery also.
Yes. For macro, we usually go for surgery. For micro, we can do the we can do the say medication. We
Under
can treat
mitigation.
them by surgery. We can treat them by giving the medication by pharmacology. But that is mostly in the step 2. Okay. The treatment most likely improved by directly inhibiting which other following process. Palpitation, weight loss, insomnia, loss 7 kg. Methimazole monotherapy is initiated. Which medication is started in this patient?
Antithyroid. Methimazole.
Methimazole. And what is the mechanism of action of methimazole?
Thyroid peroxidase inhibitor.
Peroxidase. It inhibits the thyroid peroxidase.
Inhibits the
Both.
oxidation
Yeah.
as
And
well as
also decrease the conversion.
organification
As well as peritoneal conversion.
and coupling as well. PTU also blocks the peripheral conversion as well. Okay. So because it is not PTU, so D is not the right answer, right? Because PTU blocks the conversion. Okay. Which one is going to be the right answer here?
B.
B.
Coupling.
Coupling.
Other than coupling, what two other function does methimazole blocks other than coupling?
Organification.
Uptake and organification.
Uptake and organification. Okay. The patient rapidly improves hypoglycemia by which of the following? So, what are the symptoms in this patient? The patient develops hypoglycemia.
Hypoglycemia.
And to treat hypoglycemia, what medication do we give?
IV glucagon is given.
IM glucagon. Intramuscular
Yes. IM.
glucagon is given. So,
Yes.
what is the mechanism of action of glucagon?
Gluconeogenesis. Increases
Glycogenolysis.
Glycogenolysis.
Yes, gluconeogenesis immediately. Gluconeogenesis take more
do
time.
increase the gluconeogenesis. Glucagon do increase the gluconeogenesis, but gluconeogenesis requires time. And he is asking us through which of the mechanism the hypoglycemia symptoms improves rapidly. Through
So it is an
gluconeogenesis,
increasing glycogenolysis.
yes, through glycogenolysis, its symptoms are going to improve rapidly.
Yes.
Glucagon do causes gluconeogenesis. Okay, but the symptom does not improve rapidly through gluconeogenesis because gluconeogenesis requires time. Okay, glycogenolysis. Okay. Inflammatory infiltration.
Tree. Graves disease.
The patient has hyperthyroidism or hypo?
Hyper.
Hyper.
The patient has hyperthyroidism, right? Okay. Which of the following improved her ocular symptoms? We have done a question on this.
Inflammation.
Steroids.
Steroid is the medication.
Steroid is used to control the
inflammation.
Not used to treat the Graves' ophthalmopathy, treated with
Inflammation.
glucocorticoids. And we know the mechanism of action of glucocorticoids is
NFKB receptor
yes,
blocker.
and a glucocorticoids affect which of the options? Which of the option is going to be the right answer?
Inflammatory infiltrates.
Iodine organification is influenced by what drugs?
Methimazole.
PTU.
Is iodine uptake option number C? Name the drug.
Also the methimazole and
Option number D.
Beta blockers.
Propranolol.
So the right answer is inflammatory infiltration. Okay. Okay. So the patient has hypoglycemia episodes here. Okay. So which of these medication can cause hypoglycemia?
B.
Leboride, sulfonylurea.
Glyburide.
Sulfonylurea.
Sulfonylurea.
Okay, pioglitazone no, metformin no, sitagliptin no, glypuride, which is a sulfonylurea. Okay, sulfonylurea causes hypoglycemia. It can cause hypoglycemia.
B.
Okay, several grams of iodine 131 are released into the local environment. A number of workers are believed to have been exposed to the dangerous level of radioactive iodine. Okay, by giving which of the drug we can prevent the patient from from the dangerous effects of iodine 131.
Potassium iodide.
Potassium iodide.
Why not levoth? Okay, how does potassium iodide can prevent the effect of
Wolf
a
Chaikophata.
of iodine 131?
Like competition.
Yes, it will not give the
Competes with
absorption of this
and decrease
iodine.
absorption.
By the Wolff-Chaikoff
Wolf
effect, right?
Chaikoff.
Mm.
What is Wolff-Chaikoff effect?
If we go with
Because of excess,
high doses of
excessive.
iodine, it will transiently decrease the function of the thyroid by decreasing the uptake of iodine from the blood.
Okay. Yes, when you give very high dose of iodine in the blood, the thyroid responds to that as reflexively by inhibiting the thyroid hormone synthesis. This is called Wolff-Chaikoff effect. Okay, this is called Wolff-Chaikoff effect. Okay, this is also explained in Wolff-Chaikoff effect. Protective autoregulation, sudden exposure to excess iodine temporarily turn off the thyroid peroxidase enzyme and then blocking the thyroid hormone synthesis. Okay, so in this way, we can prevent the use of the radioactive iodine by the cells. Okay, because the cells are going to shut down and they will no longer use the iodine 131, and eventually it is going to be excreted out of the body and the harmful effects can be prevented. Okay, by preventing its use by the thyroid hormone. Okay, this is called Wolff-Chaikoff effect. Okay. Okay. So what is happening in this patient? There is a 48-year-old woman comes to the office for the follow-up of type 2 diabetes mellitus. She has diabetes for 10 years with gradually worsening glycemic control despite taking multiple oral anti-diabetic medication. The patient discontinued her oral medication and started a daily injection of insulin glargine. Okay. And the patient reports a 4.5 kg weight gain. She says, I feel like I need to eat more. If that's how insulin is going to be, then I don't want to continue it. Okay. So what do you think? Why is this increased weight gain in this patient? Is it due to that due to the insulin, or does that the patient is eating more?
Eating more.
Yeah,
Eating more.
I feel like I need to eat more.
Yeah.
If that's how insulin is going to be, then I don't want to continue it. Okay. So what statement we should give this? What response should we have in response to this patient statement?
B would be the appropriate one.
Regular exercise can reduce the insulin-induced weight gain. What are your current exercise habits? Okay, by asking this question, we cannot clarify whether this patient is the cause of weight gain. We cannot clarify the weight gain cause. We need to first verify the weight gain cause here, right? Sometimes stress can increase your appetite. How are things in your life right now? Unfortunately, also insulin control it can cause weight, but the beneficial effects outweigh the, okay, in option number D, we are clearly saying that the insulin is the cause. But right now, we are not sure whether insulin is the cause or whether there is some behavioral effects are involved. Okay, so the best statement that can clarify what is the cause of weight gain in this patient is some patients eat more after starting insulin because they fear they. Have you noticed that happening to you? Okay, B is the right answer. Insulin do causes weight gain, okay? Is my screen is showing to you?
No.
No.
No, no.
Sorry. Okay, so the answer is we will ask what is the cause. We will ask whether the patient is eating more because of a fear of that his sugar may drop. Okay, this will clarify the situation. The treatment with canagliflozin is initiated. Okay, what is the mechanism of action of canagliflozin?
Sodium glucose cotransporter inhibition.
When the glucose reabsorption is stopped, what will happen to the urinary glucose secretion?
Will be increased.
Will increase.
Urinary will be increased.
Excretion will increase. Yeah.
It is going to
Sodium will decrease.
Sodium content will be decreased.
And as act as the diuretics also.
okay. Total body sodium count is going to
Decrease.
Decreased.
it is going to decrease because it is a sodium glucose co-transporter inhibitor, right?
Yeah.
So due to which the sodium reabsorption is also decreased and extracellular fluid volume is also going to decrease. Okay, so we have added an insulin therapy which the patient is taking 3 times a day. Okay, so if the patient is taking that insulin 3 times a day, is it short acting one or medium acting, or
Short acting.
the patient is taking that insulin 3 times a day? Okay, if it is short, yes. If it is a rapidly acting, name the insulins which are rapid acting.
Lispro,
Yes.
Aspart,
Risperidone and glulicine. Rapid
Glulicin. Yeah.
acting.
And the short acting is regular, intermediate acting NPH. So, so the answer would be
A.
Aspart.
I
That's
think
A.
rapid acting
A.
should be given A as
yes,
part.
yes. A would be the right answer. Okay. Long acting we take only once daily. Basal intermediate acting we take twice daily. And the short acting we take 3 times before each meal. Metformin is discontinued and glipizide is initiated. The new therapy is most likely to increase it, which of the following?
Hypoglycemia.
The sulfonylurea is the
C.
glipizide and it causes the hypoglycemia.
Because glipizide is a sulfonylurea, and we know in sulfonylureas there is
Glucose
increased
independent
risk of
insulin.
hypoglycemia. The patient has excessive thirst, frequent urination. Okay, and then hemoglobin A1C is 14%. So we started the patient on insulin in the same manner that mimics the physiological pattern of insulin release. Okay. So what will be the right answer here?
B. Insulin glargine once daily and Lispro each meal.
Okay. Rapid acting insulin controls what glucose? Postprandial or
Postprandial.
fasting?
Postprandial.
Postprandial.
Postprandial, rapid acting postprandial.
And the fasting hyperglycemia is controlled by what?
Long acting.
Glargine, long acting.
By the glargine long acting.
Long acting.
And so to control both the fasting and the postprandial, we are going to use a combination of fast acting and a long acting. Okay. Long acting controls the fasting and rapid acting controls the postprandial. So what is happening in this patient? What's the diagnosis?
Like panic
Hypertension.
attack type.
The patient has
Panic attack.
Yes, I think
Hyperthyroidism.
panic attacks, tremors and weakness.
jitterness, frequent mood swings, and palpitations for the past 2 months. And times her symptoms make her worry that she may not having a heart attack. No prior medical condition. Warm, moist skin, and okay. If the patient has panic attack, why the patient has tremor of the fingers?
Yeah, it's not episodic too. So it's a continuous.
Yeah,
So maybe
because
hyperthyroidism.
yeah, because panic attacks have episodes, right? When the patient is normal, you are not going to see the episodes. You are not going to see fine tremors, right?
Yeah.
You can see tremors in panic attack, but panic attack is not going to be present for 24 hours, right?
Yeah, yeah, right.
And also
And
there is
fine tremors are
corpuscle
present
spasm.
for the 24 hours.
Yes.
So the diagnosis here is
Hyperthyroidism. Yeah.
okay. For hyperthyroidism, which one is going to provide the fastest relief?
Beta
Fast
Beta
blockers.
blockers.
beta blockers are going to provide the fastest relief. Methimazole is also used in the hyperthyroidism, but they are not going to provide the fastest relief. Okay, because they decreases the production of the thyroid hormone, and that requires time. Okay, so that's why D is the answer.
Yeah, and also differentiate in panic attack. There is normal and there is tachypnea, but here is respiratory rate is 12 is normal. And in panic attack, also there is carpopatous spasm due to hypocalcemia, alkalosis respiratory, and it's also absent in this patient.
Okay, so the patient has hypoglycemia, but even when the patient has hypoglycemia, the patient is not showing signs of hypoglycemia, like the sweating, diaphoresis, palpitations. The patient is not showing the signs of hypoglycemia. Okay, why the patient is not showing the signs of hypoglycemia when the patient, even when the patient has a glucose level of 42, which is very low? Which
Due to
of the drug
beta
can
blockers.
block?
Beta blockers.
The history of hypertension, he is taking beta blockers.
Yeah, the patient also has hypertension history, and we know that beta blockers can mask the effects of hypoglycemia, right?
Adrenergic.
Beta blockers can mask the effects of hypoglycemia. In patient with may occur in the absence of preceding neurogenic e.g. beta blocker use, hypoglycemia unawareness in the beta blocker use. Okay, in that you are not going to see the diaphoresis, tachycardia, tremor. Okay,
Apa yang bergerak dalam mecahan misalkan harga ni
What is the insert, doctor?
yes,
The
beta
insert.
blocker. Oh, beta blocker.
Oh, Pulmonary. Okay.
Okay, because of the beta blocker, the patient is not seeing the symptoms of the hypoglycemia. Okay, because beta blocker blocks the sympathetic nervous system. Okay, and when sympathetic nervous system is blocked, the diaphoresis, sweating, all these symptoms which usually arise due to the hypoglycemia are no longer present, and this is called hypoglycemia unawareness. Okay, even when the patient has low blood glucose, the patient will not feel the hypoglycemia. Okay, hypoglycemia unawareness. This condition is called. So this is the last question for today. Okay. Which of the following is an additional effect of SGLT2 inhibitors?
Diuretic effect additional because of excretion of sodium and glucose through the urine. It will increase the
Increased fluid retention. Increased fluid retention is the effect of what drug?
increased fluid retention. This
Pioglitazone.
pioglitazone. Yes.
Okay. Okay. Increased risk for fasting. Okay. It will decrease what? Blood pressure. Okay. In heart failure patient, in those diabetic patients which have heart failure, we gave SGLT2 inhibitors. Okay, weight loss, decrease the blood glucose, decrease sodium, decrease the blood pressure. Okay, decreases the blood pressure. Okay, so this is all for today. We have done 45 questions today. So tomorrow we will do the remaining 21 questions of the pharmacology, and we will start the anatomy physiology tomorrow. Okay, so please come prepared tomorrow. Okay, and the ones who haven't still cleared the dues, please clear the dues. Okay. Okay, so thank you. Goodbye.
Thank you, Doc. Thank you.
Okay.
Thank you very much. Thank you. Bye-bye.
Thank you, doctor.